Once again, welcome everyone. Mantri is on our chief guest is on the way, so we are started for next lectures. We are honored to have with Dr. Dhaval Parmar as a scientist HTI in Gandhinagar. His extensive expertise spans evaluating health technology, cost-effective healthcare intervention, and shaping policy frameworks that enhance the value of healthcare delivery. He will be enlightening us on the topic economic evaluations in healthcare, cost-effectiveness analysis. I would request to Dhaval sir to enlighten us.
Good afternoon. Uh, let's have a snippet of cost effectiveness analysis. So, before starting directly jumping to the cost effectiveness, we must know some basic information about health economics. So, why health economics is in focus nowadays? Because uh, in world in each field, not just in a medical field, but there we have to take some decisions, and those decisions are always tough to take, especially by the ruling government or the uh, elected members or panels, and it is always tough for them to decide whether to go for option A or option B or option C. So it is always about to set the priorities, and on the basis of priorities we are going to take decisions on any of the interventions that could be either of healthcare related or education, road, job creation, housing, food, etc. Or else it can be a scenario of healthcare versus education, road, job creation, housing. So where to invest, where to uh, again, if we are if we take our context, then we are working in a medical college, we are working in a healthcare setup where on daily basis we are having dilemma to take decisions, and those decisions are always in a good faith that this could be the good decision, and we are just following our mind, or we are just following our heart. But scientifically if we are thinking, then there are many ways by which means we can decide it with evidence based. And for that, health economics is there, which uh, which is the social science that analyze the production, distribution, and consumption of goods and services. And health economics specifically uh, help us to decide when the scarcity in the allocation of health and healthcare. Means when we are having n number of expectations, we are having n number of we are having a number of desires, that if we say if we talk about public health program, then we are having 1 to 10 programs. Say for example, we are also taking the NVBDCP vector-borne diseases, we are looking for TB, we are looking for anemia. Likewise, different many programs are there. So which program needs more allocation of money, more grant? So by to decide that particular part, we need health economics help, and for that purpose we go for cost effectiveness also. So any economic analysis always involves choices between two or more than two options. There must always be a comparison, option A or option B or option C, where health economics come and takes place, help us in decision making. Health economics is having two major compartments, ingredients. One is cost, and other one is health outcome. So what is cost? So cost is basically the value of the resources used to produce something. That is the typical definition of cost. And costing relates or identification can be done by the measuring and valuing the resources consumed by the intervention. and this quantifies resources used, interviewed staff observed, or consultation time following patient time, and this summarize in a unit cost or prices. So basic understanding of opportunity cost: if you are investing in option A, then you are not going to invest in option B, or option B will suffer. So value of best alternative uses of resources is your opportunity cost. One in, one out. So if you are choosing one option A, then you are not going to, you are uh, not allocating your money or time to option B. So there is elimination of option B, and that cost is known as opportunity cost. So the opportunity cost of one course of in vitro fertilization, IVF, can be the opportunity cost of one half of cochlear implant, 9 cataract removals, 1 bypass, 3/4 of school teaching assistant for a year, 300 vaccination for measles, mumps, rubella, 1/4 hundred of challenger, 2 military tanks, 500 school dinners. So these are the opportunity cost we are paying for one IVF course. So this is how opportunity cost works. So we have to think twice before deciding uh, any of the option, and this cost are having different perspective. Cost always have perspective. So there are major three perspective. One is patient perspective or individual perspective. Second one is the healthcare or government perspective, and third one is major societal perspective. So societal perspective considers both the cost, government as well as patient or individual. So it depends on what type of question we are having. On the basis of that question, we are defining that our perspective would be by patient perspective or government perspective, or either it would be societal perspective. Societal perspective considers productivity cost, presentism, absenteeism, early retirement, premature mortality, time cost of informal carers, and patient, particularly if we talk about out of pocket expenditures, which is again a major issue, and on that basis only government has come with PMJY Yojana to reduce the out of pocket expenditure. So major cost categories are falls into three categories: direct cost, indirect cost, and intangible cost. So direct medical cost would be having the cost directly related to medical expenses which patient or which are suitable intervention is facing. The non-medical cost may consider out-of-pocket expenditure, travel cost of that patient, etc. Indirect cost may have the loss of time, loss of wages. Societal perspective may consider loss of production or pay. And intangible cost, which is hard to define, is non-financial, means anxiety, pain, depression, etc. That can be quantified in a monetary terms, but there are methods. So to estimate such cost for health sector, visit to doctor, visit to nurse, visit to outpatients, visit to inpatients, all this cost can be considered for health sector. For social services, and similar for the other travel, childcare, parking, etc. So now we are continuously talking about the cost, but from where we can derive those costs? Do we need a particular primary study to derive any cost, or we are having some database? So we are having luckily we are having one good database, that is NHSCD, National Health System Cost Database, and it is comprising most of the cost related to healthcare. Fine. So we can use that for studying any of the cost. Apart from this, many major surveys are also there. Ongoing surveys are also there: National Sample Survey, National Family Health Survey, Economic Survey of India. So these all databases help us to identify different costs This is how cost calculation take place. We have to define the number of resources used, and we have to multiply it in with the unit cost. We can have a look on the example: 3 visits with a nurse. The cost is derived, so 3 into per visit cost is 650, so it is 1950 for that particular nurse visit cost. Similarly, we have to identify each and every minute things to cover up whole cost, and it is very difficult to categorize all the costs. Again, important aspect is time horizon. Time horizon is also important while defining the cost. Second parameter was the health outcome. So costing was done for economic evaluation. I had told you that two major parts are there. One is our cost, and second one is health outcome. So for health outcome, it should be expressed in terms that are relevant to patient, provider, or decision maker. And if we talk about the health outcomes, there are certain data sources available. We can directly we can directly consider those databases to retrieve our health outcome data. uh, from 2 days you are learning about the systematic review and meta analysis. So ultimately those session helps you to perform cost effectiveness or economic evaluation. So by SRMA you are extracting those data, either it is of clinical effectiveness or cost effectiveness, and ultimately you are applying it in a economic evaluation. So this is the basic concept of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease infirmity. Now we had heard about the quality of life. Will not go in detail, but we are having two parameters from quality of life. That is, let's take this example. When we are considering health outcomes, this is the important parameter, that is health related quality of life, HRQL. So different patients are having different perspectives. One is having issues related to mobility, pain, and fatigue, which is again attributed to bio. Patient 2 is having issues related to family functioning and marital functioning, which is again a social issue. Third one is having anxiety, depression, fear of cancer, recurrence or progression, which is again psychic issue. So all different individual are having different suffering, and to derive something from that is very tough. And for that purpose, we are having these are the factors which are particularly affecting our HRQL, and majorly there are tools available to derive this HRQL. Eurocall is having EQ 5D 5L, which is most popular. 5D means it is covering 5 dimensions, and 5L means it is covering 5 levels. So which are the 5 dimensions? That is mobility, self care, usual activities, pain or discomfort, anxiety or depression. And again, all single question is having 5 level of answer, that is given in this 5 levels, that is no problem, slight problems, moderate problems, severe, and extreme. So there are gradation of each and every level. By collecting these information we can derive quali. Again, one more thing is that visual analog scale, that is again we can collect from patient itself. So this is the concept of quali. Here we'll directly jump to the comparison of quali and dali. So these two parameters are there, we can use widely in economic evaluation. that quali is quality adjusted life years and DALI is disability adjusted life years. Both are both will be expressed in either 1 to 0, where in quali 1 is perfect health and 0 is the death. That is totally inverse to DALI. In DALI we are having 0, that means perfect health, and 1 is death. So these are the major four economic evaluations. Uh, Cost minimization, where we don't consider any outcome, we just focus on the cost portion, that we are having two intervention or we are having two medicines, and we are just looking for the how we can minimize the cost. So that study is known as cost minimization. Same way, cost utility analysis, which is also using cost per adjusted life years, which use quali, and cost benefit analysis, where we are converting our health outcome benefit into monetary terms. And again, our area of interest is cost effectiveness. So cost effectiveness is a method used to evaluate the cost and health outcome of different interventions, helping decision maker to allocate resource efficiently. So if we are having two intervention, say for example, for TB diagnosis, if we are having any newer intervention or newer technique which detects TB at very early stage, then we are having dilemma that whether to go with this newer intervention or not. At that time, cost effectiveness analysis takes place, and which help us to get decision on the basis of scientific evidence. Now, cost effective analysis can be carried out by ICER, that is ICER, incremental cost effectiveness ratio. ICER means difference in cost divided by difference in health effect or health outcome. So that could be outcome, could be any, that could be the clinical success of the treatment. We can also take natural outcomes if we are looking for any test. Say for example, if we are looking to point of care devices, then we can take cost per test as a denominator. So similarly, quali can also be considered for cost effectiveness ratio. So if we are having ICER, means if we are having incremental cost effectiveness ratio, then directly we can jump into the decision or not. So for that purpose, to derive ICER, it is not that much simple as we had shown in the this formula, but it takes modeling, and modeling help us to derive our ICER. There are major two type of models, that is it is also known as decision analytic model. Two type of models are there: decision model as well as Markov model. Decision model is widely used, and it is unidirectional in flow. Means we are having two different one is intervention and one is our comparator. Then we directly have to put it in a decision model. One arm will be so this is a decision tree model, where decision node is given in a square, which is known as decision node. Round is known as chance node, and the terminal end is given in a triangular form. So this is how decision tree model looks like. I think this would be the clear image which we can discuss, that if we are considering two options, one is intervention, one is comparator. Intervention means newer technique, and comparator is which is ongoing. So when we are having intervention, so here we are having two things: we are operating and we are not operating. If we are going to operate, not operate, then disease may present, disease may absent. If disease is absent, that is the terminal node, where our decision tree this branch will end. Again, if disease is present, then what happens? either it would be cured or not cured. So our decision tree take this branch to this level, cure and not cure, starting from whether we are going to operate or not operate, whether we are going to operate or not operate, that could be towards the cure and no cure option. Similarly, we are going for operation, then disease may present, disease may absent. Again, it would be having possibilities that try for the cure and palliate. If try for the cure, then it will also having two possibilities, probabilities, that either patient may survive or operative date. If patient survive, then there are two possibilities, it will be cured or not cured. Similarly, if it look at this branch, then the disease may absent. Again, two possibilities are there, operative death or survive. So we have to derive whole scenario first. If we are talking about any of the disease, it may have uh, n number of possibilities or probabilities, and we have to capture it in a decision tree model. Probability would be in 0 or 1, and this would be the scenario. So after doing SRMA, we are extracting some data, and those data can be fed over here. So while deciding the decision tree, before drawing any decision tree, we must know that what kind of data would be available for us to plot our decision tree, and where this SRMA may help us. So by doing SRMA we are deriving these values, probabilities, and these probabilities can be plotted in our decision tree. Again, these probabilities itself are of say for example, these probabilities shows the clinical effectiveness, not the cost. So we have to plot clinical effectiveness, and parallelly we have to say for example, if patient is going for the operation, then what are the chances that patient may have disease present and disease absent. So for this particular thing, we are having one cost, we have to identify that cost between these two probabilities, and that cost would be parallelly plotted over here. And by this means, so here we are having this parallel cost, and we are having parallel our clinical effectiveness. So clinical effectiveness parallelly compared with the cost, and that by means we are getting ICER. That ICER would be plotted in a cost effectiveness plane. Now this is the cost effectiveness plane, where uh, x-axis is having it's for the treatment, and y is for the cost. So whatever the ICER we are getting, that ICER would be plotted in this cost effectiveness plane, and that particular dot falls in which section. So for this section, it is the newer this new treatment more effective but more costly. If it falls inside this quadrant, if it falls inside this quadrant, means in negative, then it is the new treatment dominates. If it falls in this, then new treatment less costly but less effective, and existing treatment dominates. मतलब हमारा जो कंपेरेटर था वो डोमिनेट यहाँ पे कर रहा है. अगर इन केस वी आर गेटिंग आवर आइसर वैल्यू इन दिस टू क्वाड्रेंट्स, देन आवर usual care is proper, and it must be continued. But if we are looking, if we are our ICER is falling in these two quadrants, then our newer treatment or newer intervention is effective. Let's take an example. This study was carried out by IIPHG, and it was for the project Lifeline ECG facility at PHC level of Ahmedabad. In that we are having ECG screening devices, and we had placed it at PHC level. So for that we had considered that either patient go for no screening or screening. So if patient go for screening, there are two probabilities that if the patient may get screen positive or screen negative. अगर screen negative हो रहा है, that is the end of this branch. If patient get screen positive, then what are the probabilities? Either it may get diagnostic positive or diagnosed negative. If diagnosed negative, then that is the end of that branch. But अगर diagnosed positive है, then it may have this many probabilities. Either arrhythmia, activation sequence disorder, hypertrophy, myocardial infarction, or other disorders. And again, each disorder may have either morbidity or mortality. So we had derived all these probabilities from primary data as well as literature by performing SRM. So we were having some primary data too, and these are the transition probabilities. That ECG screening, how there is a probability of 0.4% screen positive patient. There is probability of screen negative patient is 0.96. So here it is 0.4 and here it is 0.96. These are the probabilities. Then again it goes forward. Similarly, we are having all the probabilities for each and every branch. So these are the transition probabilities. Earlier was of intervention, and this is for the comparator. Now these are the cost parameters. Again, for each probability there is certain cost. We have to identify that cost also. So these are the cost parameters we had considered for our study. This is the cost of whole program. So at the end of this exercise, we are getting two different. This is the life year saved for 14, and for if patient goes for ECG screening, then life year saved there 14, and cost is around 7,200. If patient doesn't go for ECG screening, then life year saved are 11 and cost is 534. So by using this data, we had calculated ICER, and ICER was plotted in this CE plane, cost effectiveness plane. So this dot is our ICER. So what quadrant it represents? This is our treatment, this is cost. What does this mean? यहाँ पे ये डॉट आ रहा है, what does it mean? Okay, cost effectiveness है, but anything else? यहाँ पे आपका लाइफ ईयर सेव्ड हो रहा है, ठीक है 3, बट यहाँ पे आपके पास कॉस्ट भी है. So our intervention is cost effective. Fine. Again, this is the case. If you are going to understand this CE plane, this lecture is over. Otherwise, it is very tough to teach cost effectiveness in half an hour. But again, our dot was falling in this area. So new treatment more effective but more costly. इफेक्टिव तो है ही, बट कॉस्ट भी बढ़ रही है आपकी फॉर पर पेशेंट, ठीक है. सो हियर वी कैन रिकमेंड दैट ईसीजी स्क्रीनिंग के लिए आप अगर आप सोच रहे हो, गवर्नमेंट इज थिंकिंग अबाउट इट, तो दे कैन गो फॉर इट. बट अगेन वहां पे एक एडिशनल आपकी कॉस्ट बढ़ेगी. कितनी बढ़ेगी वो भी आपको मिल रहा है. अगेन आफ्टर दिस से फॉर एग्जांपल अगर आपका कोई इंटरवेंशन है एक्स वाई जेड, कोई भी डिवाइस अगर आप कोई नया इंट्रोड्यूस कर रहे हो, देन एट दैट टाइम इन केस अगर आपका इंटरवेंशन 2 क्वाड्रेंट में नहीं आ रहा है, कॉस्ट इफेक्टिव नहीं है, देन यू कैन गो फॉर अनदर एक्सरसाइज, दैट इज द थ्रेशोल्ड, कॉस्ट इफेक्टिवनेस थ्रेशोल्ड, जहां पे आप कंपनी को बोल सकते हो कि अगर आपका डिवाइस का ये कॉस्ट अगर रहता है, इस लेवल पे रहता है, देन इट वुड बी कॉस्ट इफेक्टिव. And there are multiple cases where HTAIn had dealt with this. Multiple tests are there कि जो इनिशियली 300 पर पेशेंट टेस्ट कॉस्ट होती थी, दैट वुड बी अराउंड, अब कॉस्ट इफेक्टिवनेस के बाद में वो 80 रुपीज पर पेशेंट आ रही है, 300 to 80 rupees. Imagine the cost saved by doing this simple exercise. So after overall, this is the cost effectiveness, economic evaluation of cost effectiveness, and this is the main thing. I think this should be understandable. uh, so in summary, decisions are unavoidable to distribute finite health sources. When we are having, when we had discussed the opportunity cost, that if we are choosing option A, then we are having opportunity cost of option B. So we have to choose it very wisely, and to decide any of the to take any of the decision, we must consider the evidence based decision making. That would be very much helpful, and nowadays HTIN is working, and lot many examples are there. So this is all about cost effectiveness and the basic introduction of health economics. Thank you. Any questions?
Actually, that what topic Dr. Dhaval explained, previously, that for the diagnosis of any cardiac problem, what facilities are available at PSC, primary health center? Is there any ECG?
Mhm.
Then, if anyone has cardiac problem, where they will be take treatment? Tertiary healthcare facility. But if you provide ECG at PSC, you will save the life. So some technology came. They says that okay, it's a portable ECG. It could be implemented at the PSC level.
I'm very sorry to interrupt. The GPS is on the way. So yes, sir. So I would like to request Dr. Bhavani sir to felicitate Dr. Dhaval sir. Thank you, sir.
Thank you. Thank you, sir.